Okay, hey everybody. Good morning. It's Dr. Arafage from Vet Triage. It's Monday, December 2nd, 2024, 11:58 a.m. Pacific time. We are on our very last article here in the May 2015 edition of Veterinary Surgery. We're going to be talking about an equine study, end-to-end versus side-to-side Jejunocecostomy in horses, a retrospective analysis, 150 cases. So I'm going to try and be a bit more elaborate with these papers and see if that generates more audience members. Oh, thanks for the heart. Thank you. Appreciate the love. So I'm going to describe more of these words. So when you have end to side, first talk about jejunocecostomy. Jejunocecostomy means that you're taking the jejunum, so jejuno, and you're attaching it to the cecum, right? Ostomy means you're creating an opening, a stoma. That's where ostomy comes from. So normally between jejunum and cecum is the ileum, okay? So the small intestines go from duodenum, jejunum, then ileum, and then cecum is the beginning of large intestine. Well, if you have to remove the ileum in a horse, then you have to attach the jejunum to cecum. They have to go together. You can either do that in an end-to-side fashion, meaning you take the end of the jejunum and it goes to the side of the cecum, or side-to-side, where you take the side of the jejunum, side of the cecum, and put them together. So that's what they're comparing here in horses. Objective is to determine factors associated with postoperative reflux, postoperative colic, repeat celiotomy, and survival in horses after end-to-side or side-to-side jejunocecostomy. So postoperative means after surgery. Reflux means that gastric or upper small intestinal contents are coming up the esophagus. Postoperative colic means after surgery, horses show signs of abdominal pain with colic. Repeat celiotomy means you need a second abdominal surgery. Survival in horses, meaning which ones survive. It's a retrospective study, 150 horses. This comes out of Virginia, Maryland, Regional College of Veterinary Medicine in Virginia, College of Veterinary Medicine in Michigan, University of Pennsylvania in Pennsylvania, College of Veterinary Medicine in Illinois, and Rood and Riddle Equine Hospital in Lexington, Kentucky. The results showed side-to-side procedures were performed using staples or hand-sewn. Method of anastomosis did not significantly associate with the development of postoperative reflux or colic, repeat celiotomy, whether the horse was alive at discharge or 12 months after discharge. The number of years that the principal surgeon was boarded by the American College of Veterinary Surgeons significantly affected whether the horse was discharged from the hospital alive. Also, age was a factor associated with 1 year survival. Increased age and administration of prokinetic medication were significantly associated with the development of postoperative reflux. And 76% of horses with side-to-side and 87% of end-to-side were discharged alive. So pretty important results there. We'll go into more detail now. The introduction. Jejunocecostomy is a commonly performed procedure in horses with ischemia, meaning loss of blood flow and oxygen to the ileum, warranting resection. Survival for horses after this surgery is worse compared to survival after small intestinal end-to-end anastomosis. So small intestinal end-to-end means you're taking two parts of the small intestine, the ends of them, and putting them together. This is being looked at because jejunocecostomy means small intestine to large intestine, right? Jejunum to cecum. Factors influencing survival in horses after the surgery may be associated with the method of anastomosis and include anastomotic obstruction from feed impactions, luminal stricture, swelling, cecal reflux, dysmotility, anastomotic leakage and adhesions, kinking or twisting of the anastomotic site. End-to-side is performed as described by another study, whereby the aboral end of the jejunum, meaning the end of the jejunum that's pointed towards the back end, towards the rectum, is sutured to the side of the cecum between the dorsal and medial cecal bands as far proximal in the cecal body as possible. Stoma size is restricted by the circumference of the jejunum in end-to-side, but is maximized by transecting the end of the jejunum at a 60-degree angle or using S-shaped. What they're trying to do here is you take the jejunum, which is going to have a small opening, and you want to attach it to the cecum. You want a big stoma. And so there's ways of enlarging the end of the small intestine to make it larger. So that's what they mean by cutting it at a 60-degree angle or using an S shape. The side-to-side anastomosis is either stapled or hand-sewn with the axis of jejunum longitudinal to the axis of the cecum. Similar to the end-to-side procedure, the jejunum is attached to the proximal cecal base between the dorsal medial cecal bands with the blind end of the jejunum directed toward the cecal base. The surgeon determines the stoma size in the side-to-side procedure and is not limited by the circumference of the jejunum as occurs with end-to-side. Proponents suggest side-to-side is the best way to optimize the size of the stoma, preventing mechanical obstruction. However, too large of a stoma may promote cecal reflux into the jejunum and dysbiosis. Dysbiosis is an imbalance in the bacteria flora of the gastrointestinal tract. And this causes enteritis and dysmotility. The one study published in Germany in 1994 found that horses that had the side-to-side had less postoperative morbidity and better survival compared to end-to-side. Okay, materials and methods. These are from 1994 to 2007 between 5 equine hospitals. They performed intestinal resection and jejunocecal anastomosis. All of the end-to-side was hand sutured. Postoperative colic was defined as any sign of abdominal pain noted in the medical record, including the words colic, pawing, rolling, stretching, kicking of the abdomen, phlegm response, flank biting. As far as postoperative reflux goes, they define that as obtaining over 20 liters over a 24-hour period or over 8 liters of nasogastric reflux at any single sampling time after surgery. Results. The number of horses from each hospital were 31, 32, 36, 20, and 31. There were mostly geldings, followed closely by mares, and then stallions. Mean age was 12 years. The most common breed was the thoroughbred, followed by quarter horse or stock horse, followed by Arabian, and then pony. All the horses received antibiotics, either gentamicin and penicillin or ampicillin. They all received flunixin, meglumine, and polyionic fluids. Prokinetic medications included lidocaine, cisapride, erythromycin, metoclopramide, bethanechol. Now, when comparing end-to-side versus side-to-side was performed in 90 horses, a third of which had hand-sewn, the others had stapled, and then end-to-side in 60 horses, all of them were hand-sewn. A higher proportion of end-to-side had serosanguinous peritoneal fluid compared with the side-to-side group. The mean peritoneal fluid protein was higher in end-to-side compared with side-to-side. The mean packed cell volume was higher in side-to-side than end-to-side. Surgeons performing side-to-side had fewer years as a diplomat, median of 2.5, compared with surgeons performing end-to-side, median of 9 years. Surgical time median for side-to-side was longer, 180 minutes, compared with end-to-side at 165 minutes. The most common lesion necessitating the surgery were strangulating lipomas, followed by epiploic foramen entrapment and mesenteric rent entrapment. As far as postoperative reflux goes, the method of jejunocecostomy was not significantly associated with development of reflux. Age and prokinetic medications were associated with reflux. The odds of developing reflux increased 6% for each year of age. Mean age of horses with reflux was 14.7 years. Those that did not develop reflux, 10.8 years. Administration of prokinetic medication was also significantly associated with the development of reflux. That's interesting. They're going to go into it later, but you treat horses with prokinetics to try and minimize the risk of reflux. It moves the intestines along so that reflux, that movement of fluid up towards the esophagus, stomach and esophagus, is eliminated. Now, as far as postoperative colic, the method of surgery was not associated with colic. 51% developed colic postoperatively after side-to-side, whereas 32% after end-to-side. The estimated total protein at the time of hospital admission was associated with colic development. Total protein at the time of hospital admission for horses developed colic in hospital after the surgery was 6.5 grams per DL and 7.1 grams per DL for horses that did not develop postoperative colic. The packed cell volume at horse admission at hospital admission, was also significantly associated with postoperative colic. The mean packed cell volume at hospital admission for horses that developed colic postoperatively was 42%, compared with 39% that did not develop colic. Now, as far as repeat celiotomy goes, the method of surgery that was not associated with repeat celiotomy, side to side, horses had 23% repeat, 30% of which were hand sewn, 19% stapled, whereas 15% of end to side had repeat celiotomy. Packed cell volume was significantly associated with performance of a repeat celiotomy. The mean packed cell volume at the hospital admission for horses undergoing repeat celiotomy was 43% compared to 40% for those that did not have a celiotomy. Alive at hospital discharge. The method of surgery was not associated with being discharged from the hospital alive. 76% of side to side was discharged, 88% hand sewn, 68% stapled, 87% of end to side were discharged. Reasons for euthanasia in hospital include factors related to surgery and complications related to sepsis and endotoxemia. The number of years that the principal surgeon was at ACVS diplomat was significantly associated with being discharged from the hospital alive. The median number of years that the principal surgeon was a diplomat for horses alive at discharge was 7 years. Median number of years the surgeon was diplomat for horses that died or euthanized before discharge was 1 year. Horse age was not significantly associated with survival to discharge. However, survival to discharge for horses less than 13 years old was 90%, which decreased to 76% for 16 to 33-year-olds. Finally, horses alive at 1 year. 85% of side to side and 85% of end to side that were discharged alive were still alive 1 year after surgery. Age was associated with being alive. Mean age of horses alive at 1 year was 9.7 versus those that died, which were 19 years. Horses were alive 1 year after surgery with 12-month survival data available for 37 horses that had the surgery performed between the ages of 13 to 33 years of age, and 73% of these horses were alive at 1 year. There was no difference in long-term survival for end to side versus side to side. Discussion. The results contradict the results of a previous study that reported that side to side was superior to end to side. In that German study, 87% of horses with side to side were alive at the time of hospital discharge, whereas only 46% with end to side left the hospital alive. The highest percent survival for horses after the surgery was reported by another study, with 90 to 91% of horses alive at the time of discharge. One experienced principal surgeon was directly involved with those surgeries. They were side to sides in that study. We found a significant association between the number of years the surgeon was boarded and discharge being alive. Interestingly, this association was not linear but curved, suggesting that mid-career surgeons, perhaps performing the procedure more frequently, regardless of end to side to side to side, were more likely to have horses alive at discharge compared to surgeons that were newer or later in their career. The association between volume of surgery, experience, and frequency performing a procedure and patient survival is well documented in people. Patient survival was directly influenced by selecting surgeons who performed the procedure more frequently in people. Horses with a higher packed cell volume at admission had increased risk for colic after surgery, as well as repeat celiotomy. Hemoconcentration, which is what they're referring to with an elevated packed cell volume, occurs in more systemically compromised horses and is usually identified as polycythemia. Polycythemia means an increase in red blood cell mass. Total plasma protein concentration may increase acutely during episodes of hemoconcentration, but may decrease over time as the horse develops systemic inflammatory disease and depletes plasma protein as the proteins move into the extravascular space, the GI tract, peritoneal cavity. Increased packed cell volume can result from plasma volume shifting into the GI tract and or peritoneal space in response to inflammation triggered by the ischemic intestine or from sympathetic response initiating splenic contraction. Thus, packed cell volume increases as total protein decreases. Increased packed cell volume with relatively diminished total protein in these horses may indicate more cardiovascular disease, leading to increased risk of postoperative morbidity. Increased packed cell volume and decreased protein may reflect cardiovascular instability and insufficient GI perfusion that could increase the horse's risk for colic and celiotomy. Increased age was significantly associated with reflux. The cause of reflux is generally unknown, but thought to be due to ileus or simple anastomotic obstruction, such as inflammation or feet impactions that resolve temporarily in most horses. An association between advancing horse age and postoperative morbidity has been reported. Alterations in immune response, both enhanced and depleted, were documented in old horses and may predispose them to ileus and anastomotic site obstructions. Increasing age was also associated with increased risk of 12-month mortality. In our study, and also reported by others, use of prokinetic medication was associated with reflux. This is confounded by the time and duration of administration and whether or not the prokinetic was administered in response to developing reflux or as a preventative. So we don't really know based on the medical records which is the case, because it doesn't make any sense if you give them prokinetics that they'd get more reflux. End-to-side horses had more peritoneal fluid, but the side-to-side had higher packed cell volume, and the surgeons performing side-to-side were earlier in their careers, with significantly fewer years as diplomat compared with surgeons performing end-to-side. Packed cell volume on admission was significantly higher for horses that developed postoperative colic and had repeat celiotomy. The number of years that the surgeon was boarded significantly affected short-term survival. Our results suggest that both side-to-side and end-to-side are acceptable when substantial ileal resection is required, precluding the possibility of performing a jejunoileostomy, which is anastomosing jejunum to ileum. And that's it. That's the last study in this journal. We'll move on to the next one tomorrow, folks. I will be traveling for the next December 3rd to December 10th. So I won't be around much, and the times of live streams will be erratic. There may be times where I can't do it, but thanks for those who showed love during this stream, and thanks for those watching in the playback. We'll see you guys hopefully tomorrow. Take care.